Hello everyone, my name is Dr. Abraham. So today we shall have a session on angioedema. So I encourage you to subscribe, share and comment on this video so that we can make similar videos that are educational and we learn more about dermatology in people of color, that is the African population and specifically Ugandans. So in our session today, I welcome you once again to our channel and I encourage you to do the same. You share with your friends as we keep learning more and more. So today, as I said earlier, we shall look at angioedema. So, and in these pictures with me, you can see this little gentleman that was having swelling of the lips involving both the upper and lower lip. And when you look at the skin actually around looks a little bit normal. Then you also see as well in this picture, this child having swelling of the upper lip. So this is the condition we call angioedema. And if you look at our previous videos, you realize that we talked about urticaria and angioedema coexisting in the same patient, or a patient can have urticaria with actually no angioedema, or they can have actually angioedema without urticaria. So today we shall discuss the angioedema in totality. So angioedema, we defined it as a localized swelling of the deeper layers of the skin. That includes the subcutaneous layers. The subcutaneous layers, the mucous membranes, and as well as increased vascular permeability. Often occurs in areas including the face, the lips, the throat, but it can also as well occur on the hands and feet. So as we've mentioned, it can occur together with urticaria or the weaves, or it can occur alone without urticaria. Angioedema as an entity was first described by Heinrich Quincke in the 1882, and historically it was linked to hereditary forms, which were identified in the 19th century. But later on, the aspect of allergic reaction was also implicated in development of angioedema. So angioedema is also classified furthermore, where we look at it as either is it hereditary, meaning that someone has a genetic defect that results in two disorders that can cause angioedema, or we can also look at it as acquired, where someone is born without any genetic defect, but later on in life, they acquire this condition. And sometimes it can also be associated with allergic reaction. That one is called allergic angioedema, which is basically mediated by immunoglobulin A, and is associated with allergic reactions like food, drugs, and the rest. We can also have drug-induced angioedema, typically to the angiotensin converting enzyme inhibitors. And then you can also have idiopathic, where you have no identifiable cause. So these are the 5 categories of angioedema. So furthermore, if you are to look deep in the hereditary type, hereditary can be type 1, type 2, or type 3, whereby in type 1, someone has a deficiency in the C1 esterase inhibitor enzyme, enzyme inhibitor deficiency. Then in type 2, someone has a dysfunction in the C1 inhibitor, C1 esterase inhibitor. And then in type 3, C1 is normal, but someone has other factors, other factor or other mutations that contribute to the angioedema. So how common is angioedema? So angioedema affects approximately 1 in 50,000 individuals globally, and the hereditary type is shown to, or is taken to be, an autosomal dominant condition. And then acquired type of angioedema is actually more rare compared to the hereditary forms. And then the one that is drug associated is common in patients that are taking SCE inhibitors. And the African population, or us, we are at a more risk of developing this type of drug-induced angioedema. So the etiology, as we've mentioned, we still take it to be due to hereditary forms or gene mutations that lead to a dysfunction or deficiency in the C1 esterase inhibitor. And then the acquired form are oftentimes linked to autoimmune conditions or even malignancies that cause autoantibodies that end up destroying the C1 esterase inhibitor protein or enzyme. Then allergic reactions, sometimes food and medication or insect stings, can also result into angioedema. And in that case, the cause will be the antigens or the toxins from these insects. Then the SAA inhibitors, these are now drugs that usually they are used to treat hypertension, and these drugs, they cause a disorder in the bradykinin pathway. So because of that, they cause increase in bradykinin, and at the end of it all, you have increased vascular permeability, but because the bradykinins are vasodilators. So when you go to the pathogenesis of angioedema, so basically we have majorly two mediators, the bradykinins and then the histamine. And in this case, bradykinins being the primary mediator in hereditary or drug-induced angioedema, the major effect is causing vasodilatation that increases vascular permeability with eventual leakage of proteins and plasma into the interstitial spaces. Then histamine is involved when it comes to allergic or idiopathic angioedema. And in that case, we know that histamine is also a vasodilator and it causes the same process. So when you have C1 esterase inhibitor deficiency, then you have uncontrolled activation of the complement system. And in that case, you have excessive production of bradykinins, which end up causing the vasodilatation. So you see oftentimes, for example, in the hereditary types of angioedema, if someone has a deficiency in C1, that is complement protein 1 esterase inhibitor, so meaning that the complement system via the C1 will not be inhibited, because after activation of the complement, then you should have a regulatory process that stops the complement. But if you don't, then continuous activation will lead to accumulation of the end products of the complement. At the end of it all, you have excessive production of bradykinins and you end up with angioedema. So how does angioedema present? So most times we have swelling, which can be sudden, localized, or sometimes involving the skin and mucosa. Common sites include the lips, the eyes, the tongue, the throat, extremities, and genitals. So it will give you this type of non-pitting edema, and the swollen areas will be firm with no depression when you press, and sometimes patients will complain of pain and discomfort. If it is excessive, you can end up with actually respiratory concerns like airway obstruction and with eventual difficulty in breathing. And in this case, you can even end up having to do a tracheostomy to help the patient breathe. So in this picture, now this is angioedema of the lower lip in an African patient. Now this is angioedema of the upper lip, still in an African patient. But it can occur when you have all the lips involved, like in the first picture that we saw, or you can have it even involving the upper limbs and the lower limbs. So this table, I like it because it helps us to classify urticaria and angioedema depending on how the patient has presented. So in this case, if someone has recurrent fracturant swellings or fluctuating or transit swellings on the body, so if someone has wales, we know a wale plus angioedema, then in that case, you go on the line of urticaria. But if someone has angioedema swelling without wales on the skin, then you go to the side of what? Angioedema. So even furthermore, when you look at wales and angioedema, you have to ask how long has the individual had these lesions. So if the wales last less than 1 hour, and then you are able to use a physical agent to induce the lesions to appear, then that is a physical urticaria. So if it is cold and you bring cold and someone reacts, that one becomes called urticaria. If it is solar, you bring light, you do photo testing and there's a reaction, that is still physical urticaria. So if the lesion is less than 2 hours, And if they're localized with a skin contact challenge being positive, then that one becomes contact at carrier. So someone can get maybe a contact at carrier maybe due to a particular cloth or material. So when you put it there and then they get a lesion, then and you're able to elicit that, then it becomes a contact at carrier. So if the lesion is just between 1 to 24 hours, and then you do a trial of antihistamine, if there's no response, and then you do a blood work, then you see maybe CBC, SR, then C4, and all of them are maybe normal, then that one becomes a spontaneous at carrier, meaning that you're not able to identify the cause. And if someone has lesions lasting more than 24 hours, and you take off a skin biopsy, and it gives you the leukocytoclastic vasculitis picture, then that is at cardiovasculitis. So, and if someone, if the skin lesion is normal, then you still manage as at carrier. So in this case, if I may summarize for you, so if someone has lesions on the skin which last less than 24 hours, then you have to think about at carrier straight away, right? So then depending on now the history and the physical examination and the blood work, then you can get different types of at carrier. If the lesions last more than 1 day, then you have to think about at cardiovasculitis. And if someone has now edema without wheals on the skin, then you have to think about angioedema. So when you go to angioedema, so angioedema further is classified if it is without wheals or if it is with wheals. So if it is wheals, you just go directly and manage as at carrier. But if it is without wheals, then you go to do the blood work. And the first screening test, we usually do the C4 levels. If C4 level is low, then you have to think about the hereditary types and the acquired types of what? Angioedema. So if your C4 is low, then you have to do another test, the C1 protein levels. So if the C1 inhibitor protein levels are also low, then and even in their function is low or reduced function, that is hereditary angioedema type 1. But if the C1 protein is normal but with reduced function, then that is type 2. And then type 3 is usually if the C4 levels are normal and if someone just has the mutations in the genes, but you are not but these values are all normal. Then it will be acquired if you do that. If someone has still C4 levels will be low, but at the same time they'll have normal or even reduced protein inhibitor protein levels, and in this case you have a reduced C1 inhibition function and then also reduced C1q levels. So that will be now acquired. So now furthermore, acquired is now classified either type 1 or type 2 or type 3. So depending on what caused, we said acquired is associated with malignancy. So someone will have autoantibodies against the C1 inhibitor proteins. So in type 1, someone has the mechanism being immune complex mediated, meaning that you have your autoimmune antibodies, which are mediating the reaction between which are mediating the destruction of C1 inhibitor protein, resulting into a consumption or destruction of all the C1 inhibitor esterases. Then in type 2, of the acquired form, in this case, someone uses, you have inhibitory antibodies that are targeted against the C1 inhibitor proteins or the C1 inhibitor esterase. So in this case, you have antibodies, here you form immune complexes. So when you go to the hereditary type, as we've said that in type 1, someone will have low antigenic and functional C1 esterase inhibitor protein. So that will be your type 1. Then in type 2, the C1E1 will be normal or even elevated, but they are not functioning. So you just have dysfunction. So their level is okay or even elevated, but they're not working. But in the first type, their levels are low and then the function as well is low. So in type 3, you have them being normal function and normal complement, but someone still ends up with edema. Then in the acquired types, we have type 1, which is usually associated with the lymphoproliferative diseases or malignancies like leukemias, lymphomas, and that one, the mechanism is immune complex mediated. Then in type 2, you have autoantibodies directed towards the C1E1 enzyme or protein. Then in type 3, it is idiopathic. We don't know the exact cause. So when you still do histology, this is still dermal edema. You'll see increased fluid in the dermal layers, as you can see here, separating the collagen bundles. So all these spaces that you're seeing here in between the collagen bundles, it is just water or edema. So that's how the picture will be. And then the infiltrate will be usually a mixed picture, like now these are eosinophils, as you can see in this picture, these are eosinophils. So depending on the trigger, then you'll have either lymphocytic, neutrophilic, or eosinophilic infiltrate. So how do we manage angioedema? So angioedema, depending on the phase, if it is acute phase, you have to give the antihistamines. If the trigger is allergic angioedema, then we can give epinephrine in severe allergic reaction, which may be precipitating anaphylaxis, to try and calm down the reaction. Then you can also give the C1 esterase inhibitor concentrate, or even bradykinin inhibitors, because we've seen them in the mechanism. So those ones can be beneficial in hereditary angioedema. Though these are not very available medicines in our setting, but it is good to know that they exist. Maybe one time they will be available. So we can also give corticosteroids in severe cases, where someone has swelling and then airway compromise. We can give corticosteroids, which is usually given as oral or IV medication. So in long-term management, if it is hereditary angioedema, we can give a prophylaxis of C1 inhibitor, protein replacement therapy, or we can also give androgens like danazol is available. We can also give antifibrinolytic agents, and then we can also give newer therapies, which we have bradykinin receptor antagonist, though these are not yet available in our setting. So in case if it is drug-induced, you can discontinue the drug, especially the ACE inhibitors for pressure. Then you can replace them with other classes of drugs to manage the patient's pressure. If there's any other causative agent that you have been able to identify, then you eliminate it, and the patient will be okay. So the complications of angioedema are similar to those that you see in the urticaria, including airway obstruction, anaphylaxis, and then the chronic recurrence, which impacts the quality of life. So the current updates are all research in angioedema. We have seen that they are trying to develop monoclonal antibodies to see that they can target the bradykinins and then the complement pathways, the C1 esterase inhibitors, such that we directly inhibit the pathway, and we end up achieving the control of this angioedema. Then gene therapies have also under investigation to see if they can do any gene therapy to address the mutations or the genetic component of this hereditary angioedema. Newer drugs are still under trial, like the bradykinin receptor antagonists are being tried out. So when they're out, then we shall see how they will impact our patients. Then currently the focus is on improving the long-term prophylaxis and then acute treatments for the hereditary angioedema to improve someone's quality of life and take away the discomfort and even risk of death. Thank you for watching. See you in the next video. I'm Dr. Abraham from Angoedema Dermatology Specialist.